Thank you.
Ladies and gentlemen, good afternoon. It's an honour to be able to present this work that we've done at Bart's Heart Centre, actually. Recovery following operation, a quality assessment system, is essentially a product of multidisciplinary working. And we'll aim today to essentially describe our motives and our journey thus far. It's not over yet. Introduce the ROQAS system to you. We thought it sounded quite a cool name. And talk about the lessons learned in the past 6 years, as well as discussing how we see the evolution of it and the future. But at that point, I'd be very interested to see your collective, maybe guidance as to where you think we could take it as well. Now, the motivation, just like you, we're part of a multidisciplinary team. We take someone who walks in from the street or in an ambulance. We try and do our best for them. We want them to get better. We want to return them to their family in a healthy state to enjoy their life. And that's what motivates us to do our work and was the driver behind this project. Usually our efforts result in a good outcome. But sometimes they don't. Sometimes people die. And we record that in a national database, and we pat ourselves on the back and we say how good we are, because we are. But there are other morbidities that occur, sternal wound infections, leg infections, chest infections, and there are people that deviate off course and have suboptimal progress that maybe it's not a full-blown sternal wound, but they're in for an extra 3 days, they get a bit of antibiotics, they go home, they have a leg wound that comes back to clinic. And we really know that feeling. And I'm sure if you're in clinical practice, you know it too, where you think you've done your best and then bam, it hits you, one of these situations. The somewhat famous American literary figure said there's only one thing more painful than learning from experience, and that is not learning from experience. And that really is a theme of this work. So what we were trying to do is prospectively, in real time, get continuous post-operative inpatient progress monitoring. We wanted to develop a simple and time-efficient, importantly time-efficient, method and robustly collect the data. And essentially use it to optimise patient care. I'm not talking about avoiding disasters here. I'm talking about deliver spot-on care each time and every time. We're a long way off that, but we're trying. Importantly, there's no funding for this. This is a clinically driven project by the nursing staff, the SCPs, the registrars, the consultants. And we used a good contact, a friend of mine who's got a PhD in physics, and essentially handcuffed him to a desk and said, start typing. And so he designed a bespoke software, which originally was just put together in an Access database. It's evolved, and now it's written in a slightly more visual, basic, and SQL database. But they're simple things, and we're happy to share with anyone. It's subdivided into 3 sections. The first and second are somewhat similar to the PATS database, the things, the national data set that we put in. But the third is really a scrutiny on the post-operative progress. To try and generate optimal care, we had to somewhat define optimal normal progress. And we felt in our unit at this time it was 5 days for a set of grafts, 1 day in ITU, 1 day in HDU, 3 on the ward. For a valve, similar, but an extra day on the ward. And you know that feeling too. You've done an operation, you've been involved in the care, you get the patient in, you do the operation, they go home. They go back to their family, job done. See them back in clinic, they're happy. And that's a great feeling. So we wanted to try and experience it more often. If someone deviated from this path, we had to justify why. If someone was on the path in terms of time, so if, say, the 4th day in hospital, which is the 2nd day on the ward, and they've got a chest infection, you still got to write it down. The data collection was from a team, as you can see here. It's daily input at the time of the ward round, and the decisions were from the medical lead, which is a consultant or registrar most often, or that may be A&P in the future, and essentially whether the progress is normal or abnormal, and if there are any comorbidities. And at the time of what's going on here? At the time of the ward round, it's put in a database. We timed that if someone was having normal progress, the time to input this data was 7 seconds. If there was abnormal progress, the time was 24 seconds. And I'll show you how. This is the patient input screen. And so, for instance, this is patient number. It's obviously a pretend patient, Joe Bloggs. And the details we can put in, for instance, here is consultant, close the chest, the conduit details pops up a stick man. The left radial was harvested by our SCP, SAMRA. And then once we've done that, we can record any medical problems and then save the patient. Now we'll consider two patients here. One is having normal progress after the operation. This is Jenny Smith, obviously not a real patient. Day 4, she's on the ward. They ask me, is there normal progress or has she got any problems? I say, normal progress, yes. Then we also entered this, because this was a little pet project of mine, trying to find out if we can predict the length of stay from the more mobility early on. So say she can get out of bed, and that's done, that's her entered. Move on to the next patient. So this is someone else who's a bit different. This is Joe Bloggs again. He's in ICU on day 2. Immediately, you have to justify why he's in ICU on day 2. You can't just skip ahead. And if it's bleeding, you put that. If it's prolonged ventilation, you put that. If it's no step-down bed, you pop that. And then they ask, what is the main reason that's stopping this patient moving? And in his case, it's bleeding. We follow him along on day 9. He's still in the hospital, so we hit ward. And then they say, well, why is this gentleman still on the ward at day 9? Diabetic control. And then you say, main reason he's not gone home is diabetic control. And we collect this data mandatorily on every patient every day. So the analysis, and then once we've done that, we can look back and analyse it. And we had 2 main ways of analysing it. One of them was an automated analysis. After putting 2 dates in, so if you look, say, for the month before your audit or the last 6 months, you get a spit out with 3 automated tiers of analysis, which can be immediately exported to Excel with 1 button click and automated graphs. So let's say we look at the number of patient days in each unit for each type of procedure, and then you can average them over the number of patients, and you look at your throughput as well. In tier 2, instead we're looking a little bit in a different way. This is really analysing throughput. So for instance, cabbage patients, one of them was in no days in ITU, one of them was 11 days, 8 of them were 2 days, for instance. And you can see if you're clogging up part of your system, what type of operations are there that's clogging them up, and see if you can plan your theatre list to take advantage of the currently existing buffer, that is the weekend. Currently existing, because it may not be a buffer forevermore. It also highlights patients that, for instance, have had suboptimal progress. And by double-clicking on, for instance, this gentleman, with the 22 days in ITU, it'll automatically pull up his whole patient journey. The third tier of analysis, again, lets you look at each of the units and try and see why, where your resources are being utilised. Whether or not you could move more patients forward, for instance, if you had physiotherapy and HDU, if you'd avoid the chest infections. But this database also allows some target analysis. And I'll bring you a little bit of data from 25,422 days. Clearly, to go in detail in this is beyond the scope of this talk, as I have a remaining 2 minutes and 8 seconds. But we can see that 35% of patients went through without hitting the sides. And that means with no complications in the allotted time period. And that is good, but not great, but 65 didn't. We can then look at that delayed discharge group and see the number of complications each one has. And we can see the majority are 2 or 3 or 4. We can then focus down over a time period and determine what those complications were. And if it was a result of a change in service. For instance, if the physiotherapists were no longer available on a weekend and we started seeing increased chest infections, as indeed we did, we have robust evidence to go back to the management and say this is unwise removal of funding. Additionally, we could go and look at, we had a problem with diabetic patients clogging up the wards at the end. And we realised that we were operating on people with elevated HbA1cs in an elective setting. And we said, no, we'll delay the admission, we'll sort out the diabetic control, and then we'll bring them in. We then also looked at the people who had delayed discharge and saw, for instance, in the group that had delayed discharge, the average delay was 6.3 days. 5 of those days were medical. That's legit. We were trying to work. Maybe we could have optimised it. But 1.3 of those days were social issues. So we went back and said, actually, what are we doing in those 5 days to sort out the social issues? If we can target the social issues in those 5 days, we know they're overstaying, we'll cut that down and save money. And have beds to operate on more patients. So our current focus is really on utilising this for resource utilisation, sorry to use the same word in sentence, theatre planning to take advantage of the buffer of the weekend that currently exists, and also trying to increase the financial efficiency by avoiding unwise cuts, let's say. In conclusion, it's a readily available database system that we're happy to share with anyone that wants to work with us. It's modifiable easily to specify the specifics of your unit. For instance, if you've got bespoke ITU and HDU, or if you've got them both together, or if you do a lot of fast tracks and want to send people home on day 4, it's completely modifiable. And it can be used very easily to focus the staff's efforts, enhance the patient outcomes and the throughput efficiency. When we go back to the physios and say, actually, you are avoiding chest infections, we need you in our team, you are helpful, that actually it lands on them, and it makes a strong argument. Thank you very much for your time and your attention.